My name is John Draper. I'm the president of research and development at Behavioral Health Link, and I am delighted to be with you all today featuring Dr. Maya Vijayaraghavan, who is the director of the UC San Francisco Smoking Cessation Leadership Center. Dr. Vijayaraghavan also will help us focus on eliminating disparities in tobacco use prevalence among behavioral health populations. That's the topic that she's going to be discussing today, and we're excited to hear her talk about it. So feel free to visit the Crisis Jam Learning Community site to get all the latest information buzzing around the crisis services community, as well as register for the newsletter. Now, I hate to miss a Crisis Jam, but I know where to go if I do, and that's right here on the Jam site, where I can see last week's outstanding presentations by Dr. Brian Mashara on strategies for assisting familiar or frequent callers to crisis helplines. You got to check that one out if you missed it. And you can find other news updates and resources from the world of crisis services that you might have missed. Dr. Vijayaraghavan will join the growing list of Crisis Jam presenters since 2020, now numbering close to 500 unique presenters, offering a diversity of perspectives on crisis care. So please let us know if you have a topic or we need to hear about anything from a presenter that we haven't heard from. Let us know. We've got some crisis services in the news, and here's a news update from our friend and colleague, Dr. Jack Roselle, who consulted with our BHL R&D team on building a violence assessment for our platform. Jack, you've got some news about how crisis centers can help prevent violence in your new journal article. Can you tell us about it?
Yeah, so as a lot of folks know, I spent about half my life doing emergency mental health and about half my life doing violence prevention. Obviously, there's a pretty big overlap there as well. My colleague, Dr. Lila Solomon, and I spent some time and laid out some ideas, really a playbook, a roadmap, if you will, about how we can recognize and deal with and hopefully prevent serious acts of violence like mass shootings. And in the space of threat management, we talk about this idea of being left of boom, right? So someone's building up to an attack, the attack is the boom, right of boom is maybe where we roll in with the recovery for the community. But we have a special role in prevention. We have a special need to think about our own security surfaces and what we do to make sure our teams, be it a physical facility for a walk in a residential program, our mobile teams, our phone teams during actual events. Next slide, please. And so we were able to contribute to an upcoming special issue of the Psychiatric Clinics of North America. I think a lot of you all know Dr. Margie Balfour and Dr. Matthew Goldman, who are the guest editors for that issue, which is entirely focused on crisis services. Well, I was too for the article processing fee to make it open access. It is available for free at this link or through this QR code for the next 45 days. And so I hope folks are able to take advantage of that and maybe find the article useful, but maybe also I hope you don't ever have to need what's in there, but just in case, it's a tool that's there for you.
Oh, we need that article. We need the guidance. Thank you so much. We don't talk a lot about violence, and we talk about suicide prevention, but not enough about violence prevention too, Jack. So thank you. Appreciate that. Here's another article from WPR.BRI.com in Rhode Island. They've got this 988 center there that is rocking it with a 98% answer rate and a 2% average speed of answer. Read about that when you get a chance in the link. Also, the Action Alliance's exciting 988 formative research findings on trusted messengers. That's going to be the topic for next week when we come together again for the jam session. So it's time for our crisis trivia hot seat, which is so hot that no one person can handle it alone. So we're going to pitch this question to all of you, our collective experts in the audience, and see if we can get the right answer together. And we may all have to phone a friend for this, but let's start with this preamble. Research has shown that individuals with mental health disorders such as depression, anxiety, and schizophrenia are significantly more likely to use tobacco compared to the general population. So what mental health condition is most commonly associated with higher rates of tobacco use? Is it anxiety, depression, schizophrenia, or bipolar disorder? So everybody, give us your thoughts on this if you can. I hear some people dialing, some friends out there. All right. Here's what we got. Most people are at schizophrenia, but it's really neck and neck with anxiety. Well, I'm wondering what the answer is. Let's take a look at what we got here. Okay, it's depression. I don't think anyone gets a t-shirt now. Given our answer on the hot seat question, I think we're also going to need some more schooling on this burning issue of tobacco use, mental health, and substance use from our special guest today, Dr. Maya Vijayaraghavan from UCSF Smoking Leadership Center. Dr. V, can you tell us a little bit about this important subject that we don't often talk about?
Thank you so much, John. Thanks, everyone. It's really nice to be here. I'm going to go ahead and start my presentation. The title is Tobacco Use, Mental Health, and Substance Use. My name is Maya Vijayaraghavan. I'm the director of the UCSF Smoking Cessation Leadership Center and faculty in the School of Medicine at UCSF. Next slide, please. So tobacco use in the United States is really an issue of equity and health disparities. There are 28.5 million people in the US who use a tobacco product. The population prevalence is around 11%. The most commonly used tobacco product is cigarettes, but you also have e-cigarettes and cigars. But as you can see in this infographic here, tobacco use affects some populations more so than others. I'm going to walk through some of these populations. The focus of our presentation today is people with mental illness. And you can see here that 71%, that tobacco use is 71% higher among people with mental illness than those without. Let's go through some other populations. Tobacco use is over 50% among people who identify as LGBT. Some of the rates of tobacco use is staggering in some populations in the United States. For example, tobacco use is 310% higher among people with experiencing homelessness compared to those without. And when you look at different forms of tobacco products, African-American individuals are 3 times more likely to smoke menthol-flavored tobacco products than other race ethnicities. Next slide, please. So let's come back to people with behavioral health conditions. When we talk about behavioral health conditions, we're talking about any mental illness, substance use disorders, or dual diagnoses. 35% of people 35% of people who smoke have a behavioral health conditions. These are very high rates. And when you actually look at lifetime rates of tobacco use, between 60% and 90% have lifetime use of a tobacco product. When you actually look at who's consuming all of the tobacco products in the United States, we know that people with a behavioral condition, health condition, including anxiety, depression, or substance use disorders, consume 40% of all cigarettes. Next slide, please. So let's get into some of the data. This is looking at current smoking among adults with a past year any mental illness. These data come from the National Survey on Drug Use and Health and includes both estimates from 2021 and 2022. Let's look at the 2 lines. On the y-axis, you have percentage. On the x-axis, you have the years, and the acronym AMI is any mental illness. So the line on the bottom represents the group without any mental illness. The line on the top represents the group with mental illness in the past year. You can see that there is a general trend or a decline in tobacco use between the 2 years. But really the gap between those with mental illness in the past year compared to those without mental illness in the past year continues to stay the same. So people with any mental illness are much more likely to have a tobacco use disorder or having current tobacco use compared to those without any mental illness. Let's move on to the next slide. Now, the difference is even more stark for people with a past year substance use disorder. You can again see the y-axis is the percentage or prevalence. The x-axis are the 2 years. The blue line on the bottom are for people with no substance use disorders. The T line on the top are for people with substance use disorders. You can see this big gap between those without substance use disorders and substance use disorders, and tobacco use is much more prevalent among people with substance use disorders. So let's move on to the next slide. Now, within this population, there are actually quite a few disparities. Let's focus on two groups where rates of tobacco use are really high. Those who are living at or below the federal poverty line, represented by the blue bars, and those who have experienced criminal legal system involvement in the past year, measured as arrested or booked in the past 12 months, and that is represented in the teal lines. Again, this data comes from the National Survey on Drug Use and Health. So let's walk through this. Now, if you don't have a past year mental health condition, this bar on the very left, you can see that the rates of tobacco use are high compared to the general population if you live at or below the federal poverty line, or if you've experienced incarceration in the past year. Now, if you add on mental illness, those rates become even higher. And for some groups, for example, those who report past year serious psychological distress or past year psychological distress and major depressive disorder, if you live at or below the federal poverty line, or you've had criminal legal system involvement in the past year, your rates of tobacco use are even higher. So there are some disparities among our mental health population in the United States. Let's move on to the next slide. Now, our landscape of tobacco products is constantly changing. And when I just started talking about this issue, I mentioned that cigarettes are the most commonly used form of combustible tobacco, but we also have e-cigarettes and vaping. And what is the connection between e-cigarettes and vaping and mental illness? So what we do know that people who are using e-cigarettes and vaping have double the risk of depression. They also have almost double the risk of having at least one day in the past month of poor mental health. For our youth and young adult population, e-cigarettes and vaping are associated with severe depressive symptoms and ADHD diagnoses. And there's also increased co-use behaviors with cannabis. Let's move on to the next slide. So we've talked about tobacco use being highly prevalent in some populations, and we've talked about tobacco use prevalence nationally being at 11%. We've made significant progress in the past 5 decades in bringing the population prevalence of tobacco use from what it was in the 1950s and 60s to what it is right now, which is 11%. But I'm always stuck on the statistic that smoking is still the leading cause of death, despite all of this progress in the past 5 years. And when you actually look at tobacco-related deaths in the United States, 200,000 of the 520,000 or so tobacco-related deaths in the United States are among people with behavioral health conditions. That is a very striking number and something that we all have a role to play in bringing down those disparities in morbidity and mortality related to tobacco use. Current trends actually show greater than 8 million deaths annually by 2020, and our priority populations are the ones that are most disproportionately impacted, highlighting the equity issues around tobacco use in the US. Let's move on to the next slide. So when we talk about tobacco use and the equity-related considerations, we must talk about structural factors related to tobacco use. It's not surprising that the disproportionately impacted populations in the US with relation to tobacco use are the ones that have also faced structural inequities that may contribute to high rates of use. So let's talk through some of these factors. We have racism and discrimination, which are associated with stress, and this is also linked with high rates of tobacco use. Related to a structural inequity, we know that the tobacco industry has a longstanding history of targeting racial ethnic minority groups. And the way this shows up is having high tobacco retail density in some of our low-income neighborhoods where there might be higher proportions of racial ethnic minorities living, and marketing of flavored tobacco and menthol flavored tobacco, particularly to Black African American populations, where they may be disproportionately represented among other populations that have high rates of tobacco use. We also know that housing instability, experiences of homelessness, and lack of economic opportunity, which are more common among some populations in the United States, are also linked with high rates of tobacco use. Let's move on to the next slide. Other structural factors include this issue of trauma. This is one of the main reasons we're all here today. There is a lot of trauma among our mental health populations. And when you look at some populations where these traumatic experiences are very high, including people with criminal legal system involvement and, or experiences of homelessness, the lifetime rates of trauma is over 80%. Again, a staggering number. We know that adverse childhood experiences doubles the risk of nicotine dependence. And people who experience trauma, some of them go on to develop post-traumatic stress disorder. 45% of people with post-traumatic stress disorder report current smoking. And when you actually look at the consumption of cigarettes, 73% report smoking more than a pack per day. When you look at these adverse childhood experiences that contribute to trauma, and you put that over a bed of limited economic and social opportunities and limited community environments to support thriving, we can see that tobacco use becomes very much a mechanism for coping and recovery for some of our populations. Let's move on to the next slide. So before we go on to how we address tobacco use, let's just bust some of the myths related to tobacco use among mental health populations. So one of them that is often heard is that tobacco is necessary self-medication. We all were posed with the question of which mental health conditions are most linked with tobacco use, and depression came up on top. But the other mental health conditions are also linked with tobacco. And oftentimes people think that using tobacco to treat mental health conditions is okay. And this is actually not true. There are treatments for mental health conditions that we should recommend. Tobacco use is not one of them. And this is long an industry supported myth. So another myth is that they're not interested in quitting. And what we actually have found in many different populations with people experiencing mental health and substance use disorders are that there is a similar intention to quit as the general population. Another myth is that they can't quit. Again, this is completely not true. Quit rates are the same or slightly lower than the general population, but when offered treatment for tobacco cessation, rates of quitting are similar to the general population among people with mental illness. Another thing that comes up around tobacco use and substance use is that quitting worsens recovery. Again, this is not true. What we've seen in many different studies is that quitting increases long-term abstinence, not only from alcohol use, but from other substances. And actually addressing tobacco use improves mental health outcomes. And we are all faced with competing priorities when we're taking care of our patients and working with residents and clients in our different settings. And tobacco falls lower on the priority list. And I would encourage all of us to bring it up to the top because smoking is the biggest killer for those with mental illness or substance use issues. And it's hard not to address tobacco use when addressing tobacco use can actually improve mental health and substance use outcomes. So let's move on to the next slide. So how do we treat tobacco dependence? This is a slide from Prescription for Change, which is a free resource for all of us, developed by the University of California, San Francisco School of Pharmacy. And it shows us that tobacco dependence is a two-part problem. There is a physiologic aspect to nicotine dependence where medications can help. As you all know, nicotine is highly addictive. Stopping tobacco use is linked with withdrawal symptoms that can be really uncomfortable, and medications can help with this. But the behavioral aspect of tobacco use also needs to be addressed. And it's the combination of medications for cessation or pharmacotherapy and a counseling program that can actually help people reduce tobacco use. Let's move on to the next slide. So what are the different treatment approaches? So we do have clinical practice guidelines for tobacco use and dependence, and we have several mnemonics or rubrics that we can use in our different settings, and they're quite easy to implement. The most common one that includes the 5 A's, and it stands for asking about tobacco use, advising to quit, assessing readiness to quit, assisting in the quit attempt, and arranging for follow-up. There are shorter versions of these, Ask, Advise, and Refer, and Ask, Advise, Connect. And these interventions can be done in as short a time as 3 minutes to longer periods of time for a more intensive experience, 15 minutes to an hour. And they can be integrated into every single session that you're seeing someone for their tobacco use. Next slide, please. So let's just go over what is guideline recommended tobacco treatment. As I mentioned, counseling is one of the mainstays. It includes cognitive behavioral therapy or motivational interviewing with a 5 A's approach or 2 A's and R or 2 A's and C. We also have pharmacotherapy for physiologic dependence for nicotine, and these include nicotine replacement therapy, bupropion and varenicline, which are FDA-approved treatments for cessation. Now, combination treatment is preferred over monotherapy. What do I mean by that? I mean that there are combinations of nicotine replacement therapy that can be used together, and this might be the patch and the gum or lozenge, and that is the preferred approach to using only the patch or the gum. Varenicline is the other first-line treatment option for cessation, and you could combine both bupropion and varenicline with nicotine replacement therapy. Tobacco use is a chronic condition. We treat it like we would treat any other chronic conditions, and therefore extended durations of treatments are recommended. And medications can be used to induce cessation attempts. So someone is not ready to quit, but are motivated, interested in moving in that direction, you can start medications prior to the quit attempt to help people or prime them to making a quit attempt. So let's move on. So we talked about this high rate of trauma among people who use tobacco products. And therefore, our treatment approaches must include trauma-informed care and must be trauma-informed. And this is based on SAMHSA's 4 R's, which realizes the widespread impact of trauma and understands potential paths to recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved with the system, responding by fully integrating knowledge about trauma into policies, procedures, and practices, and resisting re-traumatization of clients and staff. It's important that we integrate these trauma-informed tenets into our tobacco treatment. So let's move on to the next slide. As important as it is to integrate trauma-informed care, it is equally important to integrate lived experience. And what do I mean by this? We need to increase awareness of the role of lived experience in behavioral health care. We need to integrate lived experience workforce in the community behavioral health treatment. It is really important that we include these experiences so that we are able to provide care that is tailored to the populations that we seek to make an impact in. And this includes building a capacity for a lived experience workforce so that the people that are offering tobacco treatment reflect the population where rates of tobacco use are high, and that we continue to support their professionalism and career development in being part of this lived experience workforce. Let's move on to the next slide. Now, one way that this can be operationalized is peer support for substance use. We know that peers shared lived experiences, that peer specialists with formal training can support tobacco cessation. There are many state Medicaid programs that do cover peer-based services, and you can see here the map of the United States that the purple shaded states are the ones that do have state-covered services. The beige states are the ones that currently do not. and that there are many models, successful models of peer support for the treatment of tobacco use that have been used in homeless shelters, criminal legal settings, and in health systems. So I'll move on to the last slide. And I'm going to end by saying that tobacco use is a behavioral health issue, that we must use every opportunity in primary care and behavioral health, in acute care and reentry to address tobacco use. And it certainly will improve physical health and reduce disparities in physical health. But importantly, it will also improve mental health and increase long-term abstinence among those with substance use disorders. We must address the structural inequities that lead to high rates of tobacco use in our priority populations, and promoting widespread access to tobacco treatment will reduce these disparities. We all have a role to play, and I really encourage all of us to bring this front and center to the work that we do every day. So I'll stop there and pass it on to you, John.
Thank you, Dr. Vijayaraghavan. A really fascinating and important presentation. Again, not something we often talk about. When we think about mortality and mental health, we typically talk about suicide and suicide prevention. We don't talk about something else that we might be able to help people if they want to prevent their death through tobacco use. Just need to be advised on it. As you say, ask, advise, and connect is a way to approach, but they need a reason for living, first and foremost, too. Let's see if we can turn to the round table. We've got a few discussants here. Dr. Chad Morris, who's with the professor of psychiatry at the Wellness and Director of the Behavioral Health and Wellness Program at the University of Colorado, Karen Connor, Director of Outreach Programs, the Center of Tobacco Research and Intervention, University of Wisconsin, and Douglas Tipperman with Tobacco Policy Liaison. He's at the Center for Substance Abuse Prevention at SAMHSA. Let's start with you, Chad, if we could hear a few words and your thoughts about this presentation.
Great. Thanks, John. I've had the privilege of working with peers with lived experience over the last 25 years or so, and working in the crisis types of settings, detox, outpatient, inpatient, and so forth. And it's really, moving off of what Maya said, it's been really clear across time that we need both a top-down and a bottom-up type of intervention. Top-down meaning we really need to encourage our leadership and our providers to overtly provide these types of services. But unfortunately, historically, there's just been a lot of implicit bias against providing these services and providing the same level of access to individuals with behavioral health issues to these services. Therefore, people with lived experience they can make it clear repeatedly, year after year, that they want access to all the evidence-based treatments out there on par with the quote unquote general population. And the fact is they're extremely motivated and they can use these services as well as the general population, and they're extremely motivated to do that work. And the power of peers is that they really can share both how strong the motivation is, but the abilities that these folks have for affecting their own change, and the expectations for equitable care. And they're able to, the power of peers for me is they really bridge the gap, the trust gap that we have. So they're really able to move a system from peers from mistrust in the system to trust in evidence-based services, because unfortunately, historically, there's been a lot of valid mistrust in psychiatry and medical care, and peers are really able to, inform people, bring up that healthcare literacy, and counter what some of the things people have encountered before. They provide hope, and this isn't really a Pollyannish hope, but and it's a hope that moves past tokenism because it's steeped in reality of what these folks can do. Some other powerful things about peers is that Maya mentioned the importance of trauma-informed care. If you're involving peers in services, it is trauma-informed care. It provides a voice that's, for the often very difficult experiences that a lot of these individuals have endured, and how tobacco addiction is tied to that trauma. We know that there's a direct relationship between early trauma, ongoing trauma, and tobacco use. This is what the evidence base tells us. And importantly, peers understand that people with lived experience, they're survivors. They understand the incredible strengths that these individuals bring to not only their wellness journey, but to others. They've made it through a lot, and they have the power to continue to forge their individual wellness journey, and peers can help that. And, just two last few points is that peers are able to meet people where they're at in the community. We often hope folks can come into hospitals, they can come into primary care clinics, but often they don't have that access. So peers are able to, again, to bridge another gap and go out there and meet people where they're at. Maybe it's jails and prisons. Maybe it's in housing and homelessness types of services, or other community hubs of care. Maybe it's in a library system, some of the work we've done in training peers to do that. So whether from a financial or a return on investment perspective, ethical perspective, just being respectful and a pragmatic perspective, peer specialists are really a key to effective healthcare teams. I can say that after training about 6,000 peers to do this work nationally. And they don't replace other professionals. Yep. Often that's a concern. They just make those professionals better, and they provide an opportunity for everyone to shine in the roles that they have.
Appreciate your perspective, Chad. Let's move on to Karen if we can. Karen?
Hi, everyone. So as Maya said, you can really think about, tobacco use and within this population as sort of a health equity issue. And that means too that all of, these people, people experiencing mental health, substance use issues deserve treatment when it comes to tobacco use. And so, at any point, they should also be given, the opportunities to quit. And Maya shared, what that treatment can look like. And so I, encourage everyone to really think about the system where they work and think about how you can integrate, tobacco treatment within your organization. I think especially when we think about, people in crisis, they're not necessarily probably thinking about quitting at that point, but depending on a few moments down the line, they might be thinking about quitting. And we know that when they do quit, and they quit all substances together, the likelihood of recovery are much higher. So one thing that you can think about too is when you are thinking about treatment, there's state quit lines all across the country. 1-800-QUIT-NOW is the resource, and thinking about how the quit line can really be that treatment extender for you. People who work in behavioral health and provide behavioral health treatment are in a really interesting position because you have the skills, to help people change their behavior, but sometimes you don't necessarily have the resources to help people quit. So using the quit line as that treatment extender can be really helpful. And so, something to think about. We have on our website, if you go to uwctree.org, and I'll put the link in the site or in the chat, we do have some great toolkits about how to integrate tobacco treatment within behavioral health settings. So feel free to, use any resources you need and reach out to me if you have any questions.
Very good. Thank you, Karen. Doug?
Hi, thank you, John. Can you hear me okay?
Yeah, loud.
All right. I just want to highlight a few things. In Maya's presentation, she displayed a couple of slides that showed recent data from the National Survey on Drug Use and Health that SAMHSA conducts. And the good news is, since we've been tracking this data for many years, and the smoking rate for people with behavioral health conditions has consistently been decreasing, over the years, which confirms that people with behavioral health conditions who smoke want to quit, can quit and do quit. However, the bad news is, and that was also shown in those slides, is that compared to the rest of the population, their smoking rate still remains very high. So we still have a lot more work to do. We also can conduct a facility survey of behavioral health treatment facilities. And we have tobacco questions on that survey. And one thing that stands out in that survey is that a minority of behavioral health treatment facilities offer cessation treatment services. And I would say about just over a third offer, NRT, nicotine replacement therapy. So we definitely have room to improve, in that area. In an ideal world, cessation services would be just as accessible as tobacco products, and I would hope that would be true, in our field also. And then I want to end just, let people know that, since 2010, a key activity that SAMHSA has been doing to address this problem has been to sponsor leadership academies for tobacco-free recovery. And we've done this within states, and to date, 25 states have convened leadership academies. And these academies have mobilized stakeholders in these states to develop action plans to change practices, programs, policies to reduce tobacco use among their behavioral health population. And this has been a very effective strategy. So I'll end there. Thank you.
Thank you so much, Doug. What a fabulous discussion and overall exchange from this really enlightening presentation, Dr. Vijayaraghavan. Again, thanks to all the discussants and Dr. Maya Vijayaraghavan. And again, something I think for us all to take away is there are other ways that we might be able to prevent mortality in our behavioral health care. But the chat is alive with the importance of peer support in this, and also the importance of choice and making sure that people have the opportunity and don't feel pressured to choose something that they're not ready to choose. We also have today our good friend from SAMHSA, Dr. Richard McKeon, who's going to give us an update from SAMHSA's perspective. Richard.
Thank you, John. Can you hear me okay?
Hear you good.
Very good. So today, actually, I'm calling you from a meeting of the National Action Alliance for Suicide Prevention. And David Covington is here and asked me to send his regards to all of his friends and colleagues on the Crisis Jam for that. And the main focus of today's Action Alliance meeting has been the recently released National Strategy for Suicide Prevention and the associated federal action plan. Hopefully all of you are aware that that plan has been released. And you may not have had a chance to read all of it, but a couple of key things about it to keep in mind. One is that for the first time ever, it includes a goal on crisis services. So, and along with that goal, there are specific objectives. And also for the first time, there was released with the national strategy, a federal action plan of over 200 actions that federal agencies and departments have committed to doing with the existing or anticipated funding. And many of those relate to crisis services. And in fact, at a presentation at the 988 Grantee Conference in Chicago, I was going to list them down, but I found there were too many referencing crisis services to fit in the 10-minute time slot, that I had. And not only from SAMHSA, also crisis-related commitments from the Department of Justice, for example. I had conversations with folks about are doing a deeper dive into this on one of these crisis jams. We're looking to find an appropriate time. Let me just mention one other thing in terms of the National Strategy for Suicide Prevention. A number of groups, the Action Alliance, the Huntsman Foundation, the American Foundation for Suicide Prevention, last week did a briefing and supported a reception by the Senate Mental Health Caucus that was honoring the release of the National Strategy for Suicide Prevention. For those of you not aware, the Senate Mental Health Caucus now has 34 members, 17 Democrats, 17 Republicans, co-chaired by Senator Padilla from California and Senator Tom Tillis from North Carolina, who's the Republican co-chair, who revealed during this reception that he lost his nephew to suicide last year. But he actually, his work in this field is predated that. So there's a lot of interest. And so my main point would be, one benefit of being an old guy is that you've been around and you've seen things. And one thing that I've seen is that the degree of public policy attention to crisis services and suicide prevention that exists currently in the executive branch and the Congress in the states, that this is a window of opportunity. And you can't count on that window of opportunity remaining open forever, right? So it is so important for us to make the most use of the current opportunity. And the national strategy and the federal action plan give us a blueprint for moving forward and for supporting some of the efforts that we all feel will be life-saving. So anyway, that's all from me, John. Thanks for the opportunity.
Yeah, some more encouraging news from old man Samsa. Richard, always pleasure to hear from you and the good folks at the Action Alliance. We have some Nashville updates from Amy Brinkley. Amy?
Thank you. Good afternoon, everybody. I'm actually calling in today from Anaheim, California for the All Rise conference. And it's funny, all of the conversation, I've enjoyed the topic today and all of the conversation around the utilization of peer support. I look at the All Rise track and it's just peer support track after peer support track. And I'm pretty sure I've even seen some tobacco cessation titled presentations. So I've definitely enjoyed the conversation today. So I'm going to give today's Nashville update. And what I wanted to share today is we've been working significantly with SAMHSA's Office of Recovery to stand up the new SPARK initiative. So SPARK stands for SAMHSA's Programs to Advance Recovery Knowledge. It's SAMHSA's Office of Recovery's new Technical Assistance Resource Center that can be utilized for crisis service specific peer recovery initiatives as well if that's the need. The current information on the website focuses on equitable recovery supports, including recovery-oriented care, recovery supports and services, and recovery-oriented systems of care for people with mental health, substance use conditions, and/or co-occurring disorders. There is a newsletter now. We are already triaging TA requests, so Nashville is a significant partner in this new initiative, and I will put the link to the website in the chat. I do have to share that we have a Sparking Recovery quarterly event actually taking place this afternoon. So between 2 and 3:30, we will be hosting our first quarterly recovery sparking event, and it's going to be a interagency dialogue on a whole of government approach. So people from the local, state, and national levels will be coming together to have conversations on what's happening currently in the recovery space. And I will put that link to register in the chat as well. It is a free virtual meeting. And last but certainly not least, the newest focus for the Spark initiative is 2 on-site recovery TA. I'm sorry, let me just read it. So the TA opportunity through Spark right now is free intensive on-site and virtual TA opportunities that supports recovery at the state and local efforts. They're focusing on 6 priority topics. Those topic areas are youth recovery supports, community-based, non-government organizations and faith-based efforts, LGBTQI+, and intersectional recovery supports, implementing innovations and models, state recovery leadership, and funding. And that's really what I wanted to share today on behalf of NASPID for the Crisis Jam.
Thank
I
you.
did want to say, lastly, thank you to Dr. Hepburn, David Miller, and Kelly Maston for their leadership in the space of supporting recovery efforts and recovery leadership. The person in recovery from mental illness and substance use myself, and who worked in state government, I am just hugely full of gratitude and thankful to NASPID for their leadership in this space. So thank you for having me today.
Amen to that, Amy. That's really wonderful to hear you say that. And we do recognize the importance of NASPID's role. And let's get that recovery meeting. That sounds great. Let's get that link in the chat so people can participate. Now for our 988 legislative update, we're going to hear from Stephanie Pasternak at NAMI and Shelley Polanco at Vibrant. Stephanie?
Yeah, thanks, John. And just FYI, just going to be me today. But I'm happy to come on and celebrate the fact that we've reached our 9th 988 feast state with Maryland. So you'll see this map changing from Maryland to the gold color. So Maryland's Governor, Wes Moore, signed HB 933, Senate Bill 974 into law last week. Just to kind of recap what that bill does. So it sets up a permanent funding stream for 988 in the form of a 25-cent telecommunications fee on all Maryland residents' monthly phone bills. That's going to bring in more than $25 million a year. So I just also want to say a big congrats to Maryland, and especially Behavioral Health System Baltimore and all of their advocacy partners, of which there are many, who led the Fund 988 campaign, which actually has been going on for the last few years, though they were finally successful this year in getting that bill over the finish line. And speaking of fee states, I also wanted to highlight Vermont quickly. Their legislature passed a bill H65. This also adds a 988 fee. Now, this bill still needs to be signed by the governor. But if it is, we'd be actually up to 10 fee states, which means that we very well could be looking at 1/5 of the states having chosen to add this new funding stream to support 988 in just 2 years of 988's existence. So a lot to celebrate this week.
Wow, that is really, really great news, Stephanie. Very exciting to hear. And so you say that we don't have Shelley with us today? Uh-oh.
Sorry, no, that's the update for today.
Okay. All right. Well, thank you so much for the good news. It's always good to have updates that help us feel good about the progress we're making in the community. So let's see if we can move over to our Medicaid maven. Our Tom Betlock is going to give us his thoughts and insights regarding crisis funding through Medicaid. Tom?
John, great to be with you and everybody today. We've been talking in the Medicaid updates about the importance of engaging Medicaid as part of the partner that you want to work with in collaboration in terms of looking at opportunities as it relates to crisis financing and crisis support. And today I wanted to focus specifically on crisis financing. And Richard talked about the window of opportunity. And clearly, when you look at an overall financing strategy, it's more than just Medicaid, but Medicaid can be really an important cornerstone as it relates to overall financing. So on these calls, we've talked about the importance of advocacy. We did a survey, a couple of months ago, and from the audience, we heard that Medicaid can be an important financing stream. And I think, I brought this example forward as really an indication of how that can play. And this is in a state that has managed care. They have roughly 2 million lives. They have a single organization that's responsible for the crisis system. And in this example, they pay $9 per month in capitation for each of those 2 million lives for crisis services. Obviously, for the three-pronged approach of a call center, mobile response, and crisis stabilization, that $9 per month equals $18 million for the population, or $216 million for the full year. I think what's important is when you start peeling back the layers and looking at how the financing works as it relates to the various funding streams. So in this state that expanded its overall coverage under the ACA options, 27% of the population receives 90/10 financing, right? So the federal government is paying 90% of the overall financing for that population. The state has to come up with 10%. Every state's match is a little different on the traditional Medicaid population, but for this example, I used an assumption of 60-40. 60%, the state has to come up with 40%. Overall, that means that in a system in which Medicaid is financing $216 million per year, the federal government is covering $147 million, and the state's having to come up with a little less than $70 million. So around 68% of the financing is coming from federal sources as it relates to the Medicaid program. So, in this example, roughly 12% is going to call center support, 17% for mobile response, 71% for crisis stabilization. But what I really want to do in terms of this example is point out, the opportunity that's presented itself through Medicaid to look at overall financing as it relates to a significant piece of the overall strategy, but also as it relates to leveraging those federal dollars. We look at the combination of expansion populations for those states that have expanded, plus the traditional match, and what that really means for a state. So we'll be diving more deeply into other areas in which you can partner with Medicaid. Financing rose to the top as it relates to what this audience felt that opportunity to partner with Medicaid was. And I really just wanted to bring forward a concrete example. It shows the power of the purse strings and how collaboration with Medicaid can work towards providing sustainable funding streams for crisis services.
That's really exciting, Tom. And again, you're a living example of what you can do with Medicaid funding in Arizona. So the other ways in which other states can follow up and do something similar is really important guidance. And this is a nice roadmap for states to consider. Thank you.
And there's a lot of content out there, John. If folks are interested, we got all kinds of resources. So happy to be with you all today.
Yes, please feel free to reach out to Tom. He's got a lot to offer, and our states have a lot to offer if they can just find the cash. All right, our latest crisis talk article is going to be covered by Nashville's Christy Malik. Christy, your talk with Ralph Nieder-Westerman is really, really exciting to me because Lifeline folks labored for many years to get a Wyoming crisis center in the network. They were the only state in 2019 to not have a crisis center in the network. And of course, they have the highest suicide rate of any state in the nation. So the absence was really felt. And so when Ralph's outfit joined the network in 2020, we were all doing the Snoopy dance. So please tell us about this incredible work that Ralph and his folks at the Wyoming Crisis Center are doing. Love to hear from Ralph too.
Great, John. And thank you so much for that background context of Wyoming. So my colleague, Day Catalano, and I had the pleasure of interviewing Allison Johnson. She's with the Wyoming Department of Health. Also Ralph Nieder-Westerman, who's the executive director at Wyoming Lifeline, and his colleague, Karen Sylvester, who is the assistant executive director at Wyoming Lifeline. And as John indicated, we wanted to focus on the incredible 988 journey that Wyoming has gone through and how they went from a 0% in-state answer rate to over now 90%, all within just a few years. So, and I'm just delighted that Ralph, hey Ralph, so you could join us today. So love the background. So Ralph, it was just incredible when we were interviewing you and your colleagues to learn more about Wyoming's journey. Can you share your thoughts and reflections on how Wyoming got to an over 90% 988 in-state answer rate?
Yes, thank you for this opportunity to share Wyoming's story. It was between our center and the other center operated by Central Wyoming Counseling Service. We combined to get to this 24/7. We're very unique because we've split the state. Wyoming is very large and nobody lives here. So how do you split a state that has a lot of land mass but very few people? And we've come up with the Wyoming way of doing it is we split the state by time. So from 2 a.m. to 2 p.m., my team answers all of 988 calls to the state. And from 2 p.m. to 2 a.m., CWCC Center operates and covers it. So between these two centers and a great deal of dedication and incredible support from Alicia, and Karen on my team, we've been able to do what I thought was the impossible back in 2019.
Yeah, that's remarkable, Ralph. And it was very interesting to learn how you guys definitely designed a unique 988 system that would meet Wyoming's needs. So it was very interesting to learn some of those benefits of having the 12-hour shift and how you covered the statewide coverage. Can you go into a little bit more about how you guys maybe came up with that? And also one of the challenges, and it kind of piggybacks on what Tom was saying about Medicaid and funding, but like 988 funding and sustaining long-term funding. Can you also share your thoughts about that as well that you shared with us in the article?
Sure. I should have reread the article. It was so long. It wasn't so long ago, but there's been so much going on. You were talking earlier, and I forgot who the speaker was, about fee on phone lines. Wyoming doesn't have enough of a population to make that feasible. You'd end up having to put $10 a month to cover the cost. The state has 580,000 people in it. I used to live in San Francisco. There are more people in the city and county of San Francisco than in the entire state of Wyoming. The legislature has decided to come up with a trust fund. And the first year of the trust fund, where they created the law that created the trust fund, we were all excited, and then they put no money in it. So we had this beautiful box with nothing. This last legislative session, they did put $10 million in to the trust. So the goal is for it to be 40 to 46 million, which would then be sustainable funding. It's important that we covered the entire state because these are all small towns. I live in Graybull, population 1,651. We actually do have a traffic light, one of two in the county. And if I were in need of mental health services, I would never park my car in front of the office here in town because everybody knows my car or my truck. So people, because of the stigma of mental health and seeking help is so great here, sometimes people will drive great distances so that they're not seen as needing help. So even if we were to divide it geographically, we would need to know what the services are statewide. So between very few people and the need for for people to be able to go to services statewide, this just sort of seemed like a natural outcropping of how we got started.
Thank you so much for that. So we just encourage jammers to read the Crisis Talk article. And again, I also want to acknowledge my colleague, Dave Catalano, for assisting with the article. So John, back to you.
Thanks, Ralph and Christy. And Ralph, I'm so glad to hear that you all have come up with a solution for Wyoming. And hopefully the next big challenge for you all will be addressing a solution for mobile crisis services in that widely rural state with, again, 580,000 people. Just short of nobody living there, that's certainly enough people for us to be concerned about, and do hope that Wyoming can come up with that trust fund money to take care of those folks and extend mobile crisis services further. It's time for us to start thinking ahead to next week's jam session. We'll have the EDC's Elizabeth Box talking about the Ad Council, the Action Alliance, and SPRC's exciting formative research project on 988 messaging and trusted messengers. And you also don't want to miss the following week's wonderful show with Jess Spahn from Vibrant, talking about their efforts to extend the crisis care continuum beyond call centers. And that's 2 weeks from today. And for now, I want to thank you all for spending an hour of your busy day with us here at Crisis Jam, and we'll see you next week when we spread a little jam on your toast. Take care now.